All right, continuing with retina and systemic disease. This is sort of part 3, and I have an anonymous resident with me who's going to describe the image that he sees.
So this is a color photo of the fundus of what appears to be the left eye. Clear media. From what I can tell of the disc edge, it's somewhat blurry, but looks relatively distinct. Vessels look normal, other than kind of peripherally, inferior temporally. There's some kind of whitening over the vessel, maybe a posterior vitreous issue.
We'll
But
call it
obviously,
artifact. Yeah.
the obvious thing is the central macula is hypopigmented halo with a hyperpigmented center.
Okay.
Classic cherry red spot.
Cherry red spot. I'm going to take a couple issues with the terms that you use, but in the spirit of this game, I know that you meant whitish versus less, not whitish, right?
Right.
Hypopigmented infers that there's less pigment,
Okay.
right? And how much pigment does the retina have, or does the retina have pigment?
No.
It does have some.
No.
It's got in the fovea, the
Okay.
term macula lutea refers to those luteal pigments.
Okay.
So xanthophyll, carotenoids, etc. But really what we're getting at is, why is there whitening around the foveola? And do you know why that is? It's okay if you don't.
Is it some type of deposition?
Well, yeah, that's a good point. So sometimes it is deposition, and actually I'm not sure if I could tell you the exact etiology of the retinal whitening in this case. Let's talk about central retinal artery occlusion for a moment, because in that case, it's not strictly speaking a deposition of anything.
Mm-hmm.
It's a lack of transparency. So the retina is normally transparent,
right,
except for the luteal pigments. And when in a cherry red spot due to central retinal artery occlusion, the reason it becomes white is because it becomes opacified due to backup of axonal transport within the NFL and the inner portion of the retina, because it's no longer getting its normal blood supply, right? So
right.
It's on its way to apoptosis, or already is apoptotic. So anyway, you're basically blocking the underlying choroidal redness that
right.
you would see. So really the cherry red spot in the center is the supposedly normal redness that you would get, but it's accentuated because of all this whitening, right? So the cherry red spot differential, for clinical practice, this is not of high utility for the average ophthalmologist. It's of high utility for a test taker, or if you're in a place where you're getting a lot of genetics cases referred to you. But in those cases, they're usually coming with a diagnosis already. I've never had, again, I'm not in a high academic genetics associated practice, but I've never had somebody send me somebody with a cherry red spot and say, tell me all the things this could be caused by, and we'll do the workup. It's usually they've already sort of sorted it out. I think the first 3 listed, first 4 are helpful to know. It's always good to know at least 3 things on your differential: CRAO, and then Tay-Sachs standoff, gangliosidosis. The Niemann picks are important as well. So there was a picture of a Niemann pick earlier. I don't know if that made it into part 2 or if that was part of part 1, but we'll show that later. So this is that type B Niemann pick where you get this macular halo. Again, this isn't in the BCSC, so we're not going to spend a lot of time on it, but it's just a little bit of a difference. A well-circumscribed cherry red spot, so it just kind of differentiates itself a little bit from the other ones. There's basically 2 or 3 things to say about these images. In image A, we're seeing vascular tortuosity, right? Image B, we're seeing some retinal vascular tortuosity. D and C, I'm not sure what C is actually showing. Maybe a little anterior subcapsular cataract and a radial pattern. Certainly D is showing, I don't know why they're kind of labeled in this clockwise fashion, but anyway, this is British Journal of Ophthalmology. It's probably what they do. D, do you know what that's pointing at? It's on the cornea.
Verticillata.
Right, so you got some cornea verticillata. So this is one disease, and do you want to guess? Starts with an F, I think. What disease might be caused? Conjunctival and retinal vascular tortuosity. We had a differential of 2 things that we mentioned last week. Fabry's or fucosidosis. In this case, this is Fabry's disease. Also known as angiokeratoma corporis diffusum. It's helpful to know this X-linked. There are a lot of X-linked diseases, so at some point when I was a resident, I made a list of them. Nothing's coming to my mind as a mnemonic, so I must not have created a mnemonic for it. But they get burning paresthesias as a child. So if you had this child that comes in with tortuous conjunctival and retinal vessels, think of Fabry's or fucosidosis, and then if they've got these burning paresthesias, think Fabry's. Cystinosis, I'm not going to spend a lot of time here. Autosomal recessive, there are 3 types based on when it starts. All 3 have refractile polychromatic cystine crystals in the cornea and conj, and the retinopathy is only seen in the nephropathic type. So that would be like the infantile and plus or minus the adolescent. Again, nothing super obvious here in the first couple of images. Some RPE changes are prominent. Nothing that would just leaps out to me. Maybe there's some crystals right here along that second upper right picture. So if you get the infantile version, you're usually going to be diagnosed around 1 year of age. That makes sense. Progressive renal failure, growth retardation, hypothyroidism, and you get these patchy pigmentary changes peripherally. And then you could treat this with topical or oral cysteamine or cysteamine, not sure how you say that. And then that may help with photophobia. This is kind of, again, not something I've ever, I did see one patient with this when I was a resident. Maybe, no, I was a medical student. It was a long time ago. And the resident, the team made the diagnosis, and then I was told to come see the patient because it's probably the only one I'd ever see. Okay, so anyway, this is a video. I want you to just kind of look. So she's look. Or hold her. This is from Wills. All right. This is her looking to the left. It's her looking to the right. Okay. So, what'd you think?
I mean, she looks like she has bilateral ptosis and some kind of lid lag, or at least
maybe lid lag, but ptosis. You're right. What else?
Weakness. And then I'd have to see it again, honestly.
All right.
Like she was...
this probably won't let me show it to you again.
Oh.
But here, I think I've got something else to be helpful. It's coming up. I think I've got a 9 frame.
Okay.
Anything that stands out to you here? Media is clear. Nerve, maybe an enlarged cup to disc ratio could be physiologic.
Sheathing or just a normal shine.
That's normal shine for the from the hyaloid. Okay. Normal vessels. There's a very mild stippling of the, most noticeably superior temporally, of the RPE. Some very fine salt and pepper changes. Here's autofluorescence. A lot, all those changes are a lot more prominent. I wish I had a more peripheral autofluorescence image, but I don't. So you can see there's some kind of almost speckling going on, if you will, some dark hypoautofluorescent spots. And this is the FA. This is kind of mid-phase, and you see a lot of hyperfluorescent dots. And no, I don't have anything more to show you on that. I thought I had a 9 frame of her, but anyway, she has a limited up gaze, limited gaze in all directions. Do you know what that's called?
Ophthalmoplegia.
Right, so ophthalmoplegia. So you see some ptosis, ophthalmoplegia, pigmentary retinopathy. You want to think about any of these, CPEO, but also Kern-Sayer. So what do you want to do next to the patient that has that from a systemic standpoint? Well, let's just say you don't know which one of these she has. You want to refer to somebody in particular.
Yeah, cardiology.
Right. What are you concerned about?
Conduction abnormalities.
Absolutely good. So Kern-Sayer has chronic progressive external ophthalmoplegia. Usually onset before age 10. I think this girl was about 18. But the diagnosis has to be made by the age of 20. Otherwise, it's something else. They get these mottled macular pigmentary changes and a cardiomyopathy. So systemic drug toxicities. Did we just jump to something else here? Okay, so now we're changing subject. Sorry, I haven't seen this for like a year or two. So that's the main thing with them. And I think, did they get the WPW defect? I think that's something else, the Wolf Parkinson White with the Kern-Sayers. Okay. Yeah, I'm speaking off the cuff now. I don't have my notes. Anyway, so now we're going to talk about retinal manifestations of systemic drugs for a couple more minutes. All these drugs can lead to issues with the retina, so we'll kind of go through some of these. I'll kind of outline some of this. So color fundus photograph, right eye. and maybe some mild RPE changes and a parafoveal distribution. Hard to really make a call there. But the autofluorescence, you see that ring of hyperautofluorescence going in the parafoveal distribution. So concerns there, this would put you in the category of what? What would be your broad category of a differential?
Like a maculopathy.
Right, like a bullseye maculopathy. So we're obviously on the topic of drugs, so we're going to talk about that, but you still want to think about those other things too. That's where history comes into play. And so this also fits with, this is the same patient with a bullseye maculopathy. You see in the center you have relative preservation of the ellipsoid zone, but then just peripheral to that, you lose your ellipsoid zone, your interdigitation zone, which you can't see that well in her anyway. The ELM even kind of runs into the ground, into the RPE there on both sides of the foveola. So again, this is concerning for chloroquine or hydroxychloroquine toxicity or both. I have a copy of this. This is that seminal article in Ophthalmology, Blue Journal, February 2011, before your resident, where they basically revised all of what they recommended for screening for. This is the AAO's preferred practice patterns guidelines for chloroquine, hydroxychloroquine. Prior to that, they hadn't said anything about spectral domain OCT, autofluorescence, or even ERG in any kind of systematic, generalized way. So they came out with this. There's a little bit of some pushback because a lot of people didn't have spectral domain OCT at that time, and so anyway, they changed a lot of things, and you probably still see a little bit of carryover. We don't check color vision anymore, and that was a result of this. We get OCT on everybody, spectral domain OCT, and then I always try to do my best to document whether they have any risk factors for toxicity. So duration of dose greater than 5 years, which usually goes hand in hand with greater than a kilogram of hydroxychloroquine or 460 grams of chloroquine. Daily dose greater than 400. Really, the greater than 400 for daily dose, I don't use at all anymore. I only use the greater than 6.5 mg per kg of ideal body weight for individuals. And on my podium, if I can move this over without pulling out a plug or anything, you'll see I've got a cheat sheet, and I should probably put this online, where I look at their height, and their height dictates their ideal body weight, and then based on that, I tell them how many pills they should be getting a week. So if they are, let's say it's a woman who's 5'0", they should only be getting 10.4 pills per week maximum. So I'll basically say, listen, your rheumatologist or dermatologist, whoever prescribed you 14 or 2 a day, which is a typical dose, right? You need to drop off 4 pills during the whole week. It's got a long half-life. So unlike a lot of other medications that have short half-lives, you've got a lot of leeway. So I would say to them, this is what I recommend. I want it to be ratified by your rheumatologist. But we'll just say Sunday, Tuesday, Thursday, Friday, those 4 days, you should only take 1 pill. Now, that's hard to remember, but that's the reality. And again, I've not had anybody come back to me and say that they lost the clinical efficacy, the systemic efficacy of the medication by reducing it. And I don't have very many people I have to reduce it very much, and all the rheumatologists here have been very receptive to that. I've just had a few dermatologists that seem to be a little bit on the Luddite side. So age, elderly, systemic disease, ocular disease. This is a whole different topic. I am going to eventually come out with a little lecturette just on hydroxychloroquine toxicity, but some retinal diseases, I probably shouldn't say this, I will allow for them to have those diseases and continue their hydroxychloroquine if I can easily differentiate toxicity from the drug from that disease. I don't like doing it, but I'll make exceptions. If somebody has drusen, I really don't like them to be on the drug anyway, because I have this thought that they have poor retinal reserve, so to speak, and if they get toxicity, it's just going to be that much more exacerbated by the drusen, which is the main argument for discontinuing hydroxychloroquine, chloroquine anytime they have any underlying retinal disease. But my counter argument is risk-benefit ratio, take every patient one by one and sort of assess what their needs are. And a lot of people, if they come off of this drug, they don't really have anything else to treat their lupus or scleroderma or whatever it is that they're taking it for. So we'll kind of go through this. I'm not going to spend a lot of time on it. Again, I'm going to try to revisit a small lecture, but these are what are recommended. We see everybody every year, although the current recommendation was you see them once when they first start, and then you don't see them again for 5 years. We just don't have a system that would allow that. I get spectral domain OCT at every visit, and I get a 10-2 about once a year or once every 6 months if there's any question. Autofluorescence, I also get at every visit. I only get multifocal ERG if I need a tiebreaker. And again, I don't do fundus photography. I hope to never do time domain OCT until I go to Africa, and even then I'm not going to enjoy it that much. Don't do fluorescein, don't do full field, I don't do Amsler grade, I don't do color, don't do EOG. Okay, this will be our last little one because we can take a break. What do you see here?
So color fundus photo of the right eye, normal media, normal disc, normal vessels, and then in the macula there's a kind of circular area that's, I guess I would say, hypopigmented.
Yeah, and I would agree with you. So what you're looking at is another thing that's on sort of this differential of a bullseye maculopathy. You've got this parafoveal, sort of larger than just parafoveal, perifoveal and parafoveal area of RPE atrophy. The choroidal vessels are more prominent within that area, and the RPE does have pigment or melanin, and that appears to be less present here. So here's another case, totally different patient, totally different cause of toxicity, but again, this is more of a patchy RPE atrophy. And in the notes, it probably tells us which one is which. One of these is thioridazine, and one of these is chlorpromazine, although the chlorpromazine is very rare. So, okay, this is the last thing. I think we've already talked about bullseye maculopathy, but here it is showing up again. Stargardt's, we talked about HC, or hydroxychloroquine. Dry AMD should be on the differential, but nowadays with OCT, it's so easy to differentiate. You're going to see drusen. Chronic macular hole, again, OCT kind of knocks that one out of the park here. Olivopontocerebellar atrophy, haven't seen that yet. And central areolar choroidal dystrophy, I've got one patient that may have that. Pretty uncommon. I've got a lot of cone and cone rod dystrophy patients. Those can be, you really have to get adjunct testing to differentiate those. So this is the last slide. I have a mnemonic for this, and I'll try to come up with it in a more meaningful way, or present it in a more meaningful way. But basically, you could break up crystal and retinopathies into these three categories: systemic causes, drug-induced causes, and ocular causes. And let's see what the next slide looks like. Yeah, it's kind of getting into that. So we'll talk about this next time. Thanks.